Some of the topics we may have covered during our lectures in in the hospital also, and a lot of our patients which we see in our OPD there also. I thought we'll keep it more practical, because most of you all are practicing, and you'll see patients who are actually coming not for psychiatric problems to you. They may come to you for general medical problems. Which is the most common psychiatric problem you have seen? So how do they come? Like, am I suffering from depression, do they say? Or I have depression and treat me, like that they say? Or how do they come to you? Right. So actually you all have an advantage, because as if you're sorry? Case taking is there. Another thing, and if you are attached to maybe a clinic, or if you are attached to a hospital, maybe as a medical officer, or you have your own clinic, so patients already know you as a doctor, they know that they have to come to you for some medical problem, or they know you that you are there to help them out. As many times they find it difficult to come to a psychiatric first. Psychiatrist is something like a like a person who's treating only mad people, or it's like a big decision to come to a psychiatrist, but they'll come to you first. So you will be the first gate for them. So that's what we have seen, that 25% of our patients may be having a mental disorder. So as we seen, depression is one of the top ranking ones, but a lot of patients will come with anxiety, and the anxiety may not be reported to you as anxiety. They may come to you for high blood pressure, or they may say I'm having sweating, or I'm having insomnia, like someone said. And it's sometimes the diagnosis is not so important, because sometimes both are there present together, and they go to the family doctor first, because that's the person they know quite well. And many times we say, what is this, is this a very big disease, or is this a small disease? But actually there are a lot of, indirect costs. Like direct costs is there. Suppose you have to go to a psychiatrist, you have to give them the consultation fee, or you have to take the medicines, or they have to come to you, they have to give you your fees. That is a direct cost. But indirect costs are very much bigger, Like a person who's having depression may not go to work for 10 days. So if he's earning 500 rupees per month, per day, so that 500 rupees is gone, So 55,000 rupees are gone there, 10 days. Suppose if he is fighting with his wife, for example, like so that arguments, irritability, whatever, that may cause major problems in the house. So a lot of mental anguish is there. Then poor physical functioning, they'll say I'm having body ache, as someone said, or they'll feel that I don't want to go to work, or there's no interest. So the basically, like if he's a father, he may not look after the child, so the child may like not get interested in his studies, so it's like a vicious circle. And so social, occupational, functioning, all of them will go down. So we want to break the diagnosis. So like here, when you have come here, it's a good thing, because you are learning something, and that training is very much important. Many times patients will come to you and go. You may think it is just fever or flu, or that fatigue, or you may never diagnose it as depression or anxiety. Or if he's got insomnia, some people just give a sleeping pill and that's all. So that is not the diagnosis. That's like treating malaria with crocin or something like that. So we can't just treat any illness without going to the root of it. So that way, training in history taking, training in communication, and identifying the problems. Many times when you patients actually fear, array, now if I tell that he's got depression, then he may get scared, or he may not come to us. Or some of the patient gets scared to tell the doctor, hey, I've got depression, or I've got suicidal problem. They feel alienated, that my doctor, how will he think, or as if I'm weak, or whether I'm not strong enough to handle my problems, or I'm not a good husband, or I'm not a good father. So the patient actually feels a lot of guilt and all. And many times doctors also feel, अरे इसमें क्या है, आजकल स्ट्रेस इतना है, ट्रैफिक है, बारिश हो रहा है, आ नहीं सकते हैं, प्रॉब्लम्स है, सब लोग को टाइम लगता है घर पहुंचने को, ट्रैफिक, और इतना स्ट्रेस है आजकल, इन्फ्लेशन इतना है, everyone has stress. So what is there, but that time if we just justify the reasons, the illness is not treated. We have to identify the illness and start treating them. And sometimes as doctors, you must have seen the Munna Bhai movie, that the principal is saying, you have to be a doctor, you can't, talk about emotions and all. No, actually as a doctor, you should understand the emotion of the patient. You don't have to fall in love with the patient, or you don't have to marry him, but if you understand the patient's problem, and if you just keep a straight face, and you don't talk to the patient, that's not going to work. So you have to understand if he's having depression, if he's not talking, how to make him talk, or if you are sometimes too forceful, then he may get more depressed. So these are some things you have to learn. And sometimes the consultation time also is very short. No? You are seeing say 10 patients or 20 patients in that 1 hour or 2 hours. So you have to maybe get better at it. If you have lots of time initially, maybe in the beginning of practice, that's okay. But later on, you have to learn to maybe see patients faster and identify the patient's problem early. And as I said, many of the patients, they'll come with only somatic problems. They'll come with only physical problems. I have only this body pain, headache, no tension, doctor. Only body pain is there. But that can be a symptom of depression also. You maybe after some time when his pain reduces, next time he may come and tell you, doctor, actually I'm depressed also. So they may not open up in the first meeting. Once you get to know them, they may open up. And they are also not aware, this is an emotional problem. And as I told you, they are scared. If I tell it's an emotional problem, doctor will say, इसमें क्या है तू तेरे को इतना भी नहीं मालूम. You don't know how to handle your son, or you don't know how to handle your wife. So they fear that you may be very strict with them. And sometimes I see you are from Pune, someone is from maybe outside Maharashtra. So sometimes doctors are migrated to Bombay. And sometimes patients also migrated to Bombay. So these are different in cultures also. Sometimes like someone who's from Assam, if he tries to talk to you, you may not understand what he's trying to convey. His way of, even though if he knows Hindi also, he may not be able to tell you what he's trying to tell also. And sometimes if you are maybe from certain, maybe if you are a Hindu, some very orthodox Muslim comes and he doesn't maybe able to communicate depression or suicidal meaning in a different way, you may not be able to understand. Nowadays we see people from different walks of life also. Sometimes the CEO may come and talk to you, like he's 10,000 people are working under him. He finds it very difficult to understand simple things like if you talk to him maybe and maybe slowly calm him down, then he may start talking. So sometimes difficult patients are there because of these cultural differences. So what is the solution? As I told you, you'll have to learn to be more empathetic. So what is empathy? Anyone knows? So what is sympathy? You must have heard of sympathy and empathy.
Getting attached to patients.
Yeah.
To patients' emotions. And empathizing just to understand the emotions of the patient.
Yeah, correct. So as they say, you have to get in the shoes of the patient. Like suppose if yeah, somewhat you may get involved, but it's not like you're trying to just be sympathizing like, arey, you got such kind of problems, chalo, I'll come and help you, or not like arey, now you should be not like this with your wife, or just you can't just be like a dictator, or like a, you can understand the patient's problem. If he's in depression, okay, this is depression and we can help him out. And as I say, sometimes we are over enthusiastic. अरे और क्या हुआ ना, इसके ये झगड़ा होता है क्या, ये होता है. It seems the first 5 to 10 minutes you should not interrupt. Let the patient talk whatever he wants to talk. Sometimes you may have 100 questions, but the patient may have some 101 point which may be important and you may miss it. So first 5-10 minutes, let him talk. Whatever he wants to talk. First 2-3 minutes may be very just general talk. Then slowly you may start talking. So as much as possible, you can just say, okay, what else? You don't have to give him too many leading questions. Later on, after the first 5 to 10 minutes, then you can go into some questions. And as you said, sometimes you can ask, if you start detecting that it's like depression, you can ask him psychologically oriented questions like, are you feeling sad? How are you feeling? Is it very disturbing? Normally you will not ask that question unless he's having some psychology. Normally you'll ask, fever is how much, or how much is the headache, or where is the pain, or did you eat outside, or how much physical problems you have. But if you know it's a psychological case, then you can ask more of. So we'll come to that actually, what all questions you can ask. As he said, many of the times you have to just listen, don't talk, don't interrupt. And sometimes patient may be silent for some time, he may start crying also after. That's an important sign. If a person is crying, it's like how we see in fever, the body is hot, so crying is one of the important signs. You can keep eye-to-eye contact, tell the patient that's all private, whatever you're discussing. Sometimes you have to tell that in the beginning because they may think, the family, you may tell the husband or you may tell the father. Some patient will come with addiction, he'll say, you don't tell my father, that I'm taking drugs and also. You have